background information so that we can maximize the time of our speaker. So I'm Gabriel Altit. I'm a neonatologist based at the Montreal Children's Hospital, and it's really a pleasure and honor to be moderating this session today. We are welcoming Dr. Renjini Lalitha. Dr. Lalitha is a neonatologist and assistant professor at Western University in London, Ontario, and she's the co-lead for the targeted neonatal echocardiography program and the lead for point-of-care ultrasound program and education programs at the London Health Sciences Centre Neonatal ICU. Her research interests revolve around the application of different modalities for assessing hemodynamics during the transitional period, pulmonary hypertension, exploring the role of TNE POCUS in the BPD production and prevention. So it's really wonderful to have Dr. Lalitha with us today because we will be talking about transitional physiology, which is one of her area of key expertise. So just to give a few information before we start, the first part of the session, we will have about 30 minutes of presentation by Dr. Lalitha, which will be followed by a Q&A. So I invite everyone to put their questions in the Q&A box so that we'll able to use the last 15 minutes in order to discuss some of these questions. And then following that, we will, for the public session, it will be closed, and our panelists, which are trainees and young faculties in neonatal hemodynamics, will be logging into a new Zoom link that Laura will be providing in the chat so that we're able to have a more case-based interactive session. So I'd like to just thank Mallinckrodt Pharmaceuticals for the unrestricted educational grant that is allowing this session to happen. We are accredited by the Royal College of Physician and Surgeon of Canada for Section 1 CME credits. And it is very important that you provide us with your feedback, since we do look at this feedback and these evaluations in order to improve and tailor the content of these sessions. So please, please, please scan the QR code and provide us with your ideas, comments, and feedback. So on this note, Dr. Lalitha, thank you so much for accepting to be with us today and to present to our group, to the trainees, and to the young faculties, and to the general public attending this NHRC session. So I will let you share your slides and take over with the presentation. And I'll ask everyone to please close their microphones, because I do see a few microphones still open, and close their camera while Dr. Lalitha is presenting her talk. Thank you.
Thank you so much, Gabriel, for that lovely introduction. Feel honored to come and talk today. And so I'm just going to start sharing my screen. Okay.
We see very well.
Thank you. So I think I'll just get to business with interest of times, because I only have 30 minutes to do this. So the learning objectives for this session for the next 30 minutes, I'll try and highlight some of the pertinent adaptations that are important to know in fetal and transitional circulation, understand the differences in the myocardial structure and other associated organ systems that are important for transition in preterm babies compared to their counterpart-term babies. Identify hemodynamic changes during perinatal transition that puts this baby at a higher risk with early morbidities, particularly hypertension, pulmonary hemorrhage, and intraventricular hemorrhage, and apply some of this understanding of the transitional physiology and the disease pathophysiology to help with cardiorespiratory management within the first few days of life. So important things to know in the fetal circulation is that there is a high PVR state, so pulmonary vascular resistance is high, with a low systemic vascular resistance, and the placenta is the organ of gas exchange, where about 50% of the blood of the fetal placental circulation resides in the placenta. The LV preload is predominantly from the placenta, while the RV only shunts about 5 to 10% of the cardiac output to the lungs because of the high pulmonary vascular resistance. The rest are all shunted away to the systemic circulation. So it's important to note that in the fetus, both ventricles work together to provide the systemic blood flow. So transitional circulation begins once the umbilical cord is clamped and the lungs are inflated. So immediately after birth, there is a sudden decrease in the pulmonary vascular resistance that is aided by the inflation of the lungs, stretching of the lungs, and the mechanical release of certain pulmonary vasodilators and many other vasodilators that helps to decrease the pulmonary vascular resistance and therefore improve or increase the preload to the heart. The second phenomenon that happens after transition circulation is a sudden increase in the systemic vascular resistance that happens because of the cord clamping, as well as there are some neuroendocrine changes that happens around the time of delivery because of the stress that the baby goes through that leads to release of vasopressin and catecholamines that helps to increase the vascular resistance. So this transition goes fairly smoothly in many term babies, but can be quite challenging in babies who are born preterm, particularly babies who are born at the extremes of prematurity. And this can be further compounded by the presence or absence of antenatal corticosteroids and also lack of delayed cord clamping, concurrent birth asphyxia, sepsis, fetal growth restriction that leads to cardiac remodeling and therefore making their heart less compliant, as well as some of the intervention that these babies nearly always need, which is the positive pressure ventilation. So this slide shows how hemodynamic changes occurs during cord clamping. So normally our standard of practice is to offer delayed cord clamping in babies who are spontaneously breathing. So the flow from the placenta is still maintained in these babies. So there is increased preload that the heart gets with this maintenance of the placental blood flow. Furthermore, with the spontaneous breathing, there is decreased intrathoracic pressure that these babies generate, which further aids venous return to the heart. So overall, impact is increased in the right ventricular preload. After birth, there is a switching circulation from parallel to series. So if the right ventricle gets more preload, the left ventricle also gets that increased preload. With the umbilical artery still being patent because the cord is not clamped, this leads to continued maintenance of decreased afterload. So the two increase in preload and decrease in afterload, what it does is increase in cardiac output while the baby is transitioning out into the postnatal life. Now, what if the baby needs immediate cord clamping? This is a scenario that we see, particularly in babies who need immediate ventilatory support. So we clamp the cord, which holds all the blood flow from the placenta towards the baby. And therefore, this decreases the filling or venous return to the heart. Further complicating is the positive pressure ventilation that we are delivering to these babies, which increases the intrathoracic pressure and impedes the venous return. So the RV after preload is decreased, which lead to decrease in LV preload. And with the umbilical artery being clamped, it increases the left ventricular afterload. And therefore, the final result is decrease in the net left ventricular cardiac output. This in the context of a preterm heart who has intrinsic deficiency, not just the cardiovascular system, but its supporting organ system that interacts very closely with the cardiovascular system, makes them particularly vulnerable. So let's look at the hemodynamic consideration that we need to think about in these preterm babies. So when you look at the cardiovascular, particularly the heart, their heart has less myofibrils, so they are disorganously arranged. Furthermore, they also have a more fibrous content in the myocardium. So they are less muscle and more fibrous. And when you have more fibrous tissue and endothelial tissues that the heart is formed of, this comes with the decreased cardiac compliance. And this, when the heart undergoes even a slightest increase in afterload, the heart is unable to cope because it crosses the limit of Frank-Starling response. So what is Frank-Starling response? So this is a response that when a muscle is stretched because of increased pressure, it recoils back with a stronger force, making the contraction. In preterm babies, because they have less muscles and more fibrous, when the stretch goes beyond a certain degree, it doesn't recoil back that much, and therefore they lose or they cross over their Franz-Sterling response, leading to decreased tolerance to the increase in the afterload that they're facing. And this leads to low cardiac output state. And additionally, the presence of shunt that worsens the systemic blood flow further insults this heart. What about the vasculature? So they have decreased vascular reserve to start with because they have less number of blood vessels. These vessels store a bigger amount of blood in the body. And when a baby is in crisis, or when a human being is in crisis, they use this vascular reserve. The blood that is there in the vascular reserve is used in times of crisis when a baby is going into cardiovascular instability. Because they have decreased number of blood vessels, they have decreased vascular reserve, and therefore in times of crisis, they're unable to have enough compensatory mechanism, so they quickly tip off their compensatory mechanism. They also have a very fragile blood vessels to start with that are very leaky, and therefore they tend to lose or sweep out. The neuroendocrine system is also different in these babies. Their endogenous stores of dopamine, catecholamine, as well as their adrenal response to stress is also low. Therefore, they have a low cortisol, fairly low cortisol levels, which quickly gets depleted in states of crisis. While the renal system, which is an important system to maintain fluid and electrolyte balance in any babies, so they also have renal immaturity, which is accounted by a decreased number of glomerular count and function, and therefore low glomerular filtration rate, and decreased tubular reabsorption function, and therefore decreasing ability to concentrate urine and maintain acid-base balance, which is important for cellular function. Last but not the least, the lung. So lung and heart has a very close interaction. These babies who are born preterm, they tend to maintain high pulmonary vascular resistance a little more longer. They drop the vascular resistance a little slower. And with the fact that they also have a low alveolar capillary system, they can easily flip into hypoxic respiratory failure. And with the need for mechanical ventilation, 100% of these preterm babies need some form of ventilatory support, whether non-invasive or invasive mechanical ventilation, which alters the hemodynamics of and the loading condition of the heart. So underinflated heart or underinflated lung or overinflated lung both affects the pulmonary vascular resistance and therefore preload to the heart, and therefore impacting the hemodynamics. All these factored in with the immature myocardium, with the fact that soon after birth, they are dealing with an increased afterload as well as an increase in preload that the heart is getting. This can lead to a significant hemodynamic stress on their immature cardiovascular system, which can lead to hypertension and shock, hypoxic respiratory failure or acute pulmonary hypertension, pulmonary hemorrhage, as well as intraventricular hemorrhage. And this phenomena can be explained by preload-afterload mismatch. So generally, when you have a balance between the preload and afterload, everything is hunky-dory. But when you have a mismatch, things can go south. So what is preload-afterload mismatch? So what happens is after birth is with the sudden increase in the systemic vascular resistance. So I'm just trying to take my laser. So with the sudden increase in the systemic vascular resistance because of the clamping of the cord, there is an increase in the left ventricular wall stress. Now, we know there is also changes in the circulation from parallel to series. So fetally, both RV and LV supplies blood to the systemic circulation. But postnatally, it's the LV that supplies the systemic circulation. So there is an increased preload that the right side of the heart is now exposed to, that the right ventricle has never been exposed to. And when the right ventricle has increased preload, we also see this increased preload on the left side to supply the systemic circulation. So the left side of the heart is now facing an increased left ventricular preload. Now, over the first 24 to 48 hours, PD also start to become more and more hemodynamically shunting left to right, contributing to further increase in the left pulmonary preload. Also, additional intervention that we do in an ICU, particularly is the surfactant therapy, though transient, can also decrease the pulmonary vascular resistance and therefore increase the LV preload. Both the increase in preload and increase in the afterload or the wall stress, along with a heart that we know that is less compliant and less distensible, leads to an increase in the LV diastolic end pressure. And this in an acute phase can lead to LV dilatation, which further increases the wall stress and leads to this baby flip to the limit of the front stall-wing response, whereby the fiber can no longer shorten as it's supposed to. And this leads to LV pump dysfunction. When the LV pump becomes dysfunctional, it increases the end diastolic pressure in the LV, which leads to increase in LA pressure, and this translates into increase in pulmonary venous congestion and therefore pulmonary hemorrhage. So, left-sided intracardiac venous congestion leads to pulmonary hemorrhage. Now, what happens to the right side? So with the LV pump dysfunction, it also impacts the RV pump too, because of what the phenomena that we know, that is the ventricular interdependence. So the RV also becomes dysfunctional, and RV, like I said, is also getting more preload than it is used to fetally. So with this increased RV preload and some dysfunction that is happening to the RV, and with the LV that can dilate in the acute state, occupies and limits the capacity of the RV, further aggravating the increased RV preload that is happening, leads to increase in the RV diastolic pressure. And this translates into increase in RA pressure, which leads to congestion in the venous return to the right side of the heart, which in turn increases the cerebral venous pressure and therefore IVH or parenchymal brain injury. So congestion, intracardiac venous congestion on the right side leads to IVH or intraventricular hemorrhage. So this is studied. So this preload afterload mismatch can be studied using stress velocity relationship. Our traditional way of assessing pump function using ejection fraction and fractional shorting, which we are all so used to, is influenced by heart rate as well as the loading condition, both preload and afterload. This stress velocity relationship is corrected for these factors, and it gives you information on the wall stress that the LV is undergoing, as well as the fiber shortening that the ventricular muscles are undergoing, which both are indicative of one, the afterload, the other one being the pump function. And this can be measured using LV internal diameters, as well as the heart rate, as well as the systolic and systolic blood pressure, which is not easy to get, but can be replaced by mean blood pressure. Using that, you can calculate these two parameters. So these two parameters were studied extensively by a group in Japan. So Toyoshima, back in 2002, published his report on a study on the relationship between fiber shortening and end wall stress on a group of babies, two group of babies. One is preterm infants with hemorrhagic complications such as pulmonary hemorrhage and IVH. Two, and compared it with the group 2, which is infants without such complications. What he found was there was a significant correlation between fiber shortening and end wall stress. So increase in the end wall stress led to decrease in the fiber shortening. And when he compared between the two groups, so group 1 is the one with the hemorrhagic complication, there was a steeper slope or steeper decrease in the fiber contraction with increasing wall stress. Even with the slightest increase, there was steeper decrease. He further serially followed these markers in both these groups across the first 48 to 60 hours of life. And what he found that serially with serial echocardiogram, around 6 hours of life, both the groups started to show an increase in the end wall stress. And both the groups started to show a decrease in the fiber shortening. The peak in the end wall stress reached by 24 hours, while the nadir for the fiber shortening reached also by the 24 hours. Now, when he compared between the two groups, the babies who had hemorrhagic complication had a significantly higher end wall stress by 24 hours compared to their counterpart, which did not have hemorrhagic complications, while the fiber shortening was significantly lower in those who had hemorrhagic complication compared to their counterpart. So with this, they made a tailor-made circulatory management based on this relationship, whereby they were assessing these babies who were going into hemodynamic instability early with echocardiogram and looking for their end wall stress to understand their increased afterload, as well as the pump function using fiber shortening. And if they found that the pump function was dysfunctional, they would start them on a low dose of dobutamine. If it was afterload that was high in these babies, then they started on nitroglycerin, which is a vasodilator. With this management strategy, they compared babies who underwent this management strategies, which were in the extreme preterm babies, the 23 and the 24 weekers, compared with their historical cohort. And what they found was a significant reduction in the IVH from 22% down to 4%. And hence, they started introducing it into clinical practice. And in the 3 years of their clinical practice, they further saw decrease in the IVH. Since then, several units in Japan has introduced or adopted this circulatory management, and by doing early echoes, early serial echoes, whereby a baby is getting 2 to 3 echoes in 24 hours during the transitional period, where they not only is assessing pump function and the wall stress as well as volume, but also how the PDA is presenting. So whether the PDA is getting hemodynamically significant and consider treatment if they are suggesting hemodynamic significance. With this tailor-made approach and intense screening and circulatory approach, they were able to decrease, which is this red line is their infant mortality or neonatal mortality. They were able to decrease their neonatal mortality to a significantly lower level, which is one of the best in the whole world at this point. And they attribute to this decrease in the neonatal mortality more towards because of the decrease in the preterm mortality. And it was primarily because of the circulatory management that they did. A similar finding was also shown by Esinga and group from Iowa, where they introduced an early hemodynamic screening in these high-risk babies who are born less than 27 weeks, where early screening echoes were performed as early as 12 to 18 hours of life, looking for PDA hemodynamics, assessment of pulmonary hypertension, cardiac function, and tailor management strategies based on the echocardiographic findings. And what they did was compare with their historical cohort, and what they found was a significant decrease in the odds of death and severe IVH during the hemodynamic screening period compared to their historical cohort. Further, not only were they able to decrease the IVH, they were also able to increase survival that was free of other severe morbidities like neck and severe BPD. Additionally, they also saw an increase in the medical treatment of PDA that was significant, but came with a PDA that needed less intervention surgically. So all these assessment and the current research currently suggests that we need to have comprehensive assessment during transitional period to understand the hemodynamic changes. So therefore, a global assessment of cardiovascular status it needs to be assessed using a combination of clinical signs, biochemical data that is available through blood work, as well as incorporating it with echocardiographic parameters of assessment of cardiac function, PDA hemodynamic status, as well as systemic blood flow status. The newer modalities of assessment include near-infrared spectroscopy, where of particular, the cerebral nears is becoming more and more utilized in the transitional period to guide some of the treatment decisions regarding cardiovascular support and ventilation strategy. Even though the two recent RCTs did not show any difference in survival free of brain injury using a NIRS-guided approach. Hence, it should be used to complement, not as a single tool for intervention. So, all these methods has their benefit, but also big limitations too. Let's talk about echocardiogram. Echocardiogram is so valuable in assessing hemodynamic status because it's giving you a proxy information on the systemic perfusion as well as pulmonary blood flow and also hemodynamic status. But it is labor intensive, needs availability of trained personnel to perform and interpret these information in a timely fashion, including after hours and as well as in weekends. And such a service is a big limitation across many centers in the world, where we don't have enough capacity that we have built. Even if it is a TNE center, we don't have that capacity to deliver that 24/7 care that these babies deserve. Hence, many times the state of the matter is we are assessing these babies hemodynamically more with what is available clinically at the bedside. And one of the most common biomarker to start cardiovascular support in these preterm babies still remains being hypertensive or blood pressure values. So, what is hypertension in the transitional period? I've decided to use hypertension in the transitional period because it is different from transitional hypertension. When you talk about transitional hypertension, it should be occurring during the transitional period in the absence of sepsis, in the absence of hypoxic injury, or in the absence of a significant blood loss. So, but we know hypertension is not uncommon in transitional period. And therefore, I've decided to use hypertension in the transitional so that I include also hypertension that comes about because of hypoxia, hypertension that comes because of blood loss, hypertension that comes because of even sepsis. So our definition for hypertension has evolved over the period. One more commonly used, and it's still used by many centers, is mean blood pressure less than the gestational age. There is very low evidence to support this, and it is mainly consensus based, but it is a very quick and easy approach, and still many centers continue to use it. More recently, more and more centile charts have been published through database studies, and therefore centers are using or utilizing more of these BP centiles charts, which are more evidence-based. And one such common centile chart is the Subros BP centile chart, which is derived from a big data set that comprised of about close to 1,000 babies who were followed for the first 90 days, and therefore it probably is more evidence-based representation of the BP centiles. Hypertension remains difficult to define in preterm babies as there is still no threshold BP that still predicts adverse outcome. Because it is easily available and can be easily measured, it still continues to be used. But we need to remember that it cannot be used as a surrogate of organ blood flow because BP is a product of cardiac output and systemic vascular resistance. For example, cardiac output is what organ blood flow indicates. If you have a baby who has a low or cardiac output, the compensatory mechanism in that baby is to increase the systemic vascular resistance. And this the net result is it keeps the blood pressure normal. So you have a normal blood pressure in a baby, but this baby actually has a low cardiac output and therefore is in a low organ blood flow status. Hence, we need to use it in combination with other markers of organ perfusion, which itself also has its own limitation, that it is subjective, it is hard to interpret in certain situations, it is late in origin, and sometimes prematurity can alter some of these parameters, especially with urine output. Many times they don't go into the phase where they retain urine. Instead, they start to diurese so early in life and keep dumping and losing volume. And you also need to put all these parameters of perfusion in context with the perinatal risk factors too when you're assessing hemodynamics at the bedside in the absence of a readily available echo. So we know more and more that mean blood pressure does not give you any information on the pathophysiological process in a baby. And therefore, there is increasing realization that we should more and more look at the components of the blood pressure, because there is big utility by looking at each component of the blood pressure and assessing hemodynamics. So what does systolic blood pressure reflect then? Systolic blood pressure is basically reflects your cardiac output, or more specifically your stroke volume, which is determined by your preload, amount of blood that the heart gets to pump. Secondly is the contractility, how forcefully the heart contracts. And third, the afterload, which is how much pressure against which the heart needs to contract against. All this determines your cardiac output, and that is what the systolic blood pressure reflects. What about diastolic blood pressure? Diastolic blood pressure reflects more of your volume status and your vascular tone, or your afterload that the blood vessel has. So when you're talking about diastolic hypertension, you're either talking about a volume status or hypovolemic state, or a low vascular tone state like warm septic shock. And when you're talking about systolic hypertension, you're talking about a low stroke volume state like myocardial dysfunction, or a low preload state that we can commonly see with PPHN, or even tension pneumothorax that leads to low preload state, and intense vasoconstriction that we see in cold septic shock. And when you see combined shock, it is a progression of a disease. And here, particularly in this one, echo becomes so useful in understanding the underlying pathophysiology. And many times in this stage, you're also consider adrenal insufficiency as one of the possible causes too. So this is a chart that summarizes beautifully a suggested approach to hypertension in preterm babies, whereby the author does recommend using clinical triggers of perfusion, as well as history triggers of perfusion, and to suspect low blood flow state, where a single parameters should not make you suspect a low blood flow. You need to have combination, at least two or more of these parameters, to say that there is a suspected low blood flow state. And when you suspect a low blood flow state, you go down to see what is the pathophysiology process happening. Pathophysiology you could understand from the components of the blood pressure. So see what the components of the blood pressures are doing. If you're seeing a diastolic hypertension or a systolic hypertension or a combined hypertension. So it is important that when you understand which part of the blood pressure is affected, that you link it with the disease process. For example, if you have a warm septic shock, you present with low diastolic blood pressure. So in that case, you use your volume and vasopressor to help with the low diastolic status. But if you don't correct the sepsis, you're going into a rabbit hole that you may not be able to come out. So concurrent management of the disease also is important. Therefore, you can have a holistic approach. So using this, you can devise an appropriate management plan, and which can help out the babies using blood pressure and other perfusion markers. When you see a baby who has a dropping blood pressure and gradually dropping down to the 5th centile or the 3rd centile, acceptable, but there are no other red flags, the baby is fairly oxygenating, baby's laboratory blood work serially has also been reassuring. Here you are going to take a permissive approach and say that this is permissive hypertension, but close monitoring, because one parameter alone does not say there is low volume state. So, but close monitoring is important because you might see a trend coming by the close monitoring that you're doing. So diastolic hypertension recap is priority is volume resuscitation followed by pressing the pipe or squeezing the pipe by vasopressors. And for systolic hypertension, you manage by improving your preload with volume. In the absence of echo, you would need to use volume. But if you have an echo information, you can forego that volume if you know that the preload status is preserved, and then supporting the heart with inotropic support. When you have combined hypertension, very, very important that you have echo information to know what exactly is happening here. So use pathophysiology-based selection for cardiovascular support and judicious use of volume expansion, because we know volume expanders has been associated with adverse outcome, particularly fluctuation of cerebral blood flow, and increases your risk of cerebral hemorrhage or intraventricular hemorrhage. And also, particularly if you have a systolic hypertension, very cautious volume expanders, because if you're using volume expanders in a heart that is severely dysfunctional, you are further setting that heart to fail. Consider hydrocortisone, and especially there is no rule when you should go for hydrocortisone. Some says when you're thinking about the second agent, think about hydrocortisone. Some says when you're on two agent and you're thinking about another agent, additional agent, think about hydrocortisone. There's no strict rule, but earlier introduction of hydrocortisone, at least for us, we say in our center, we say when you are thinking about a second agent to help with the cardiovascular support, consider starting hydrocortisone. Early wean is also important because we don't know what the effects of reperfusion injury is happening to these preterm injury by keeping these vasoactive agents on board for longer. And hence, setting a parameter for early wean is paramount in these preterm babies who have vulnerable organ system, and treat other possible factors as well. So in summary, cardiovascular changes in preterm babies during transitional period can be quite complex and challenging in these babies, especially in the extreme preterm babies, because of their limited capacity to adjust to these hemodynamic changes. There exists a subgroup of patients who are high risk where a targeted preventive and therapeutic interventions are quite beneficial, as shown by the Japanese group and the Iowa group. And hence, it would be important that early recognition of cardiovascular compromise and its appropriate support be done is crucial to help improve the outcome, because we have growing evidence to show that low systemic blood flow is associated with adverse neurodevelopmental outcome. Thank you.
Okay, I will start giving some key information. First of all, Happy New Year to everyone. Welcome to the Neonatal Hemodynamics Targeted Neonatal Echo Foundation's curriculum. This is the first session we have in 2025, so it's going to be extremely exciting. Before presenting the upcoming presenters, I just want to give a few key information for everyone. First of all, I do want to mention a bit about the format so everyone is aware. We are starting with a webinar, which is open to a broad audience, and our presenters will have presentations on a key hemodynamic aspect of the practice. And after the presentation, there will be the opportunity to ask questions via the Q&A box. So please make sure to put your question via the Q&A box so that we're able to ask these to our presenters. Following that, there will be a smaller session really geared for our trainees, fellows, young faculties in neonatal hemodynamics. And for that, there will be a specific link that will be sent to the panelists, which include the presenters as well as the fellows and young faculties. So please make sure to log on the second part, which will not be recorded and which will be interactive with our presenters. On this note, I also want to mention that the Neonatal Hemodynamics and TNE Foundation curriculum is supported by an unrestricted educational grant from Mallinckrodt Pharmaceuticals. So big thanks for them to supporting that. We are accredited by the Royal College of Physicians and Surgeons of Canada in order to have Section 1 maintenance of certification credits. And then importantly, please scan the QR code and fill up some of the surveys and evaluations following this session so that we can use that to continue to bonify the curriculum and program as we use that to tailor the presentations and topics as well as the formats. So on this note, I really want to thank our two presenters today. The first ones of 2025 who will be presenting in the pharmacology of hemodynamics. We have Dr. Christopher McPherson, who's a PharmD, graduated from the University of North Carolina School of Pharmacy, completed a fellowship in neonatal pharmacotherapy at the Women's Hospital of Greensboro. He practices as a clinical pharmacist in the neonatal intensive care unit at St. Louis Children's Hospital and serves as an associate professor in the Department of Pediatrics at Washington University School of Medicine. His primary employment is as a medical science liaison for SOBI Inc. We also have Dr. Irina Prelipshan. She is a staff neonatologist at the Golisano Children's Hospital and Associate Program Director of the Neonatal Perinatal Medicine Fellowship Program and Assistant Professor of Pediatrics at the University of Rochester. She has trained in targeted neonatal echocardiography and is developing her research in hemodynamics and in biomarkers involved in neonatal brain and adrenal dysfunction.